Hi all, welcome to Grand Rounds. I am not Jeff Connors. Jeff is officially in retirement for the next month or 3 weeks. We have a great Grand Rounds today. We've kind of got a double header from the Division of Gastroenterology and Division of Endocrinology. And so we have Dr. Catenacci with us and Dr. Sulllivan from Endocrine and GI respectively. Dr. Catenacci is going to go first and pass it off to Dr. Sulllivan, and we'll take questions at the end. QR code for credit is there, and that'll be up until we get started. So I'm going to introduce Dr. Catenacci first. She did her medical school residency, chief residency at Yale. She joined us as a fellow in the Division of Endocrinology in 2004. Joined the CU faculty here in 2007 and has been with us since. She is, I was not going to say what Dr. Haugen told me to say in terms of her status, but she is a world leader in obesity with multiple R01s, a K24 mentorship award. The list of grants that she has is extensive in addition to all of her publications. We are absolutely so fortunate to have her with us today. And Dr. Sulllivan, as we were talking, spent most of her training at WashU in St. Louis. She joined us here in faculty after being at WashU for about 10 years on faculty. She joined us here in 2016 and is a full professor in the Division of Gastroenterology. She gives talks around the world. She's an educator. She writes about endoscopic management of obesity and also has a considerable publication track record as well. So we're very fortunate to have them both. And so I'll call Dr. Catenacci to the stage.
Thank you so much. Thank you so much for that kind introduction and for inviting me to speak today. I'm really excited to talk to you about something that I'm very passionate about, which is intermittent energy restriction strategies for obesity treatment. I'm going to start with a brief case presentation. This is a 38-year-old woman. She has a BMI of 31. She was recently diagnosed with prediabetes, and she wants to lose weight to reduce her risk of developing diabetes because she has a strong family history. She has no other past medical history. She works full-time. She's married. She has 3 children. Unfortunately, after some discussion, we concluded that she doesn't have insurance coverage for weight loss medications, nor can she afford the out-of-pocket costs. She does exercise regularly, walking her dog 45 minutes most days of the week. She's struggled with her weight for years and has tried multiple conventional weight loss diets, including calorie counting, low carbohydrate diets, low fat diets, meal replacements, and just finds that it's very hard to stick to these diets for more than a month or 2. She's recently heard some news reports about intermittent fasting, and she wants to know if you would recommend this approach for her. So the goal is by the end of this talk, you would have the information you need to answer this question for her. I'm going to briefly review 2 of the most common intermittent energy restriction paradigms proposed for weight loss: time-restricted eating and intermittent fasting. I'm going to discuss reasons to consider these alternative dietary strategies and outline current evidence for these strategies in obesity treatment. So humans evolved in environments where food was relatively scarce and energy intake was intermittent. And our metabolic, endocrine, and nervous systems have evolved in ways that allow maintenance of physical and cognitive performance during periods of food deprivation. However, our current environment has changed dramatically to one in which highly palatable, energy-dense foods are readily available 24 hours a day. And with that has come a shift in our eating patterns. So this, using a smartphone app, Gil and Panda monitored ingestive events in 156 non-shift working adults for 3 weeks. And this graph represents a polar plot of the aggregate data. So each little dot represents a time when someone ate more than 5 calories. And what they found was that most of their subjects ate frequently and erratically throughout their wakeful hours. The median daily eating window was about 15 hours, and there was only about 6 hours between midnight and 6 a.m. where the frequency of eating declined. And for years, we've been telling people desiring weight loss to eat less. maybe an alternative strategy for some people may be to eat less often. So I'm going to review the two most common fasting paradigms for weight loss. And one caveat is that there's really no clear consensus on the terminology. And often terms are used interchangeably in the media and by patients. In particular, intermittent fasting is often used as an umbrella term to describe really any kind of non-conventional diet. And it's really important too, if patients talk to you about, oh, I'm doing intermittent fasting, or what do you think about intermittent fasting, to really be clear about what it is they're thinking intermittent fasting is. I had one patient recently tell me that they do intermittent fasting overnight. And I said, well, what exactly is that? And it turns out that she doesn't eat when she's sleeping. But that was a win for her because she had been waking up in the night to eat. So I think it's just really important to meet people where they are and understand what they're saying when they use these terms. And for clarity, I really like to use the definitions used by Mark Madsen in his 2017 review. So time-restricted eating is a paradigm in which food intake is restricted to a window of less than 8 hours every day. The eating window can be either early or it can be shifted late in the day. And this narrowing of eating windows typically reduces energy intake by about 350 to 500 calories a day in adults with overweight or obesity. Intermittent fasting, the way that I define it, is a paradigm of a recurring pattern of little to no energy intake on fast days, with intervening periods of sort of normal or usual food intake on fed days. This can be alternate day fasting, where the fasting schedule is very rigid, meaning every other day is a fast day, or it can be 2 to 3 non-consecutive fast days a week. And these are commonly called 5-2 intermittent fasting with 2 fast days a week, or 4-3 intermittent fasting with 3 fast days a week. The fast days can be either a total fast with 0 energy intake, or a much more commonly studied paradigm is a modified fast of about 75 to 80% energy restriction on fast days. And this is typically operationalized as about 500 calories a day for women and 600 calories a day for men. And with intermittent fasting, weight loss occurs because individuals do not fully compensate on fed days for the calorie deficit on the fast days. So why consider these intermittent energy restriction strategies? Daily caloric restriction is the most commonly prescribed dietary strategy to induce weight loss. Current guidelines recommend this strategy along with a comprehensive lifestyle intervention as the cornerstone of obesity treatment. And this typically results in about 5 to 7% weight loss over 3 to 6 months. And the amount of weight loss is really minimally impacted by dietary macronutrient composition. However, many individuals find it difficult to adhere to conventional weight loss diets in which you have to focus on restricting calories or fat grams or carbohydrates every day. And regardless of the diet type used, and in this study, they compared the Atkins, Zone, Weight Watchers, and Ornish, self-reported dietary adherence during dieting declines rapidly and markedly within 1 to 4 months with traditional weight loss diets. And as a result, the majority of individuals who lose weight with traditional dietary approaches will regain. And so this is a 2001 meta-analysis of US dietary weight loss studies using conventional weight loss diets. And they found that about 35% of lost weight is regained within 1 year, and about 80% of weight loss by dieting will be regained in 4 to 5 years. So what about obesity pharmacotherapy? We've been hearing a lot about this lately. And weight loss medications clearly produce significantly greater weight loss than lifestyle interventions alone. They are indicated as an adjunct to lifestyle interventions in individuals with a BMI greater than 30 or BMI greater than 27 with weight-related comorbidities. And weight loss medications are an excellent option, but clearly they only work if an individual can afford them, can have them covered by insurance, can tolerate the side effects, doesn't have contraindications, and can actually access those medications, which is a major issue right now with the supply chain. And so lifestyle interventions really remain relevant for many individuals who may benefit from weight loss. And this, I found this just yesterday because I was like, I really need something to back that statement up. So this is a July 2023 survey, and they surveyed a nationally representative sample of US adults with overweight or obesity. And only 45% of this sample said that they would be very or somewhat interested in taking a weight loss medication if they knew it was safe and effective. And then that actually dropped to 16% if they were told the weight loss medication was not covered by insurance, and to 14% if they were told that they may regain weight if they stop the medication, which we know is true with weight loss medications. So why is fasting appealing? Why is this alternative approach appealing to some individuals? Well, conventional weight loss diets involve counting calories or carbs or fat grams. You have to measure your portions or weigh them. You have to plan your meals. You have to purchase, special diet foods. You might have to purchase different foods for yourself if you have a family. This requires a high level of executive function. It requires a lot of advanced planning. It requires mental energy, which many patients find challenging and exhausting and difficult to maintain over time. Fasting paradigms are just less complicated. One patient in one of my studies commented, this is the easiest diet I've ever been on. I just need to remember when I'm supposed to eat and when I'm not supposed to eat. In addition, the periodic nature of fasting may mitigate the constant hunger associated with DCR. So we know there are very strong metabolic adaptations to energy restriction and to weight loss that increase appetite when someone is restricting their intake. And so maybe the periodic nature of fasting kind of helps ameliorate the constant hunger and the constant drive to eat. And I think what's really important to understand is that we're not really aiming to replace conventional diets or say that fasting diets are better, but merely provide an additional evidence-based option as the best approach for any given person is the one that they feel they can adhere to over time. So I don't have time to discuss this in detail, but I just wanted to mention that preclinical studies in rodents and short-term studies in humans suggest that periods of fasting may have greater metabolic and other health benefits than traditional diets, including enhanced cognition, increased insulin sensitivity, and reduction in inflammatory markers. For the purpose of the rest of this talk, I'm going to focus on weight loss outcomes data, but I'm going to touch on some of the news reports that you may have heard about potential risks of fasting. So stay tuned for that. So current evidence for time-restricted eating as a weight loss strategy. So there have been multiple studies that suggest that TRE alone, so just narrowing eating windows without any kind of focus on improving diet quality or behavioral support, produces minimal weight loss, 0 to 3%. Probably the largest study to date was published in JAMA Internal Medicine in 2020. And they found that TRE alone produced only 1.2% weight loss over 12 weeks in adults with overweight and obesity. However, as I mentioned previously, our current obesity treatment guidelines recommend a comprehensive behavioral support program for individuals desiring weight loss. And that's typically defined as at least 14 sessions with a trained interventionalist focusing on changes in diet and physical activity. So we don't expect DCR to work without behavioral support. Perhaps it's unfair to expect TRE to produce weight loss without behavioral support either. And in fact, a recent study by Lin and colleagues published in the Annals of Internal Medicine in 2023 suggests that when TRE is provided along with behavioral support for a healthy diet, weight loss is similar to daily caloric restriction. In this study, 90 adults with overweight or obesity were randomized to TRE versus DCR versus control for 1 year. Both TRE and DCR received behavioral support for a healthy diet from a registered dietitian. They had about 24 sessions over the 1 year period. And both groups lost weight and improved body composition and metabolic parameters with no significant differences between groups. So what is the best TRE window? And I think there's a lot of outstanding questions here. Most studies use an 8-hour window. However, the optimal duration of TRE eating window is really not known. Shorter eating windows could, in theory, produce greater weight loss, but may reduce adherence. And I think well-designed studies are needed in this area. Most studies to date have used a late TRE window. So for example, noon to 8 p.m. And they kind of argue that that's most feasible for participants. However, an early window may have greater weight loss and metabolic benefits as it aligns eating with the physiologic day. And there's been some small short-term studies that suggest this, although an early window may pose issues with adherence. So again, randomized trials are needed. And one of our colleagues here at CU-AMC was recently awarded an NIH R01 to study this question. And she is currently recruiting participants for her time to eat study. So current evidence for intermittent fasting as a weight loss strategy. Multiple short-term studies suggest various intermittent fasting paradigms, so ADF, 5-2, 4-3, are safe and tolerable and produce 3 to 8% weight loss along with improvements in body composition and metabolic parameters. The best evidence to date comes from 5 long-term, so 1 year or longer, well-designed trials comparing isocaloric IMF versus DCR. So the isocaloric is really important because that means that what the study did was that they matched the targeted weekly energy deficit between groups. So that allows us to isolate the impact of the dietary pattern on the outcomes of interest, rather than having one group achieve a greater energy restriction, and then you can't really interpret the results. So of these 5 studies published to date, 4 have evaluated a 5-2 IMF paradigm, so that's 2 fast days a week, and 1 has evaluated alternate day fasting. All 5 studies showed that both groups lost weight with no significant differences between IMF and DCR. So there's one additional study that will hopefully be published soon. This is our recently completed DRIFT study. This is a 1-year randomized trial designed to compare weight loss generated by isocaloric 4-3 IMF versus DCR. And these are my co-investigators and collaborators, Drs. Bessison, McLean, Melanson, Pan, Ostendorf, and Creasy. And so our participants were 165 adults with overweight or obesity. Major inclusion criteria were diabetes, cardiovascular disease, chronic kidney disease, eating disorders, previous bariatric surgery, current obesity pharmacotherapy, or pregnant, lactating, or planning pregnancy. And these participants were randomized 1-to-1 to 4-3 IMF versus DCR. Again, the targeted weekly energy deficit was matched. Our 4-3 IMF group underwent a partial fast, 3 non-consecutive days per week, and they were given a calorie goal designed to target an 80% energy deficit from baseline energy requirements. And this ranged from about 400 to 700 calories for most of our participants. On fed days, they were encouraged to eat ad libitum, their normal diet, but asked to make healthy food choices. Our DCR group was given a calorie goal to target a 34% energy deficit from baseline requirements every day. And this ended up being between 1,200 and 2,000 calories for most participants. So in our study, we determined their calorie goals based on measured REE using indirect calorimetry times an activity factor. Both groups were guided to the same target macronutrient content. Both groups were given a guidelines-based prescription to increase physical activity. Both groups received comprehensive behavioral support from a dietitian. The randomized groups met separately, and meetings were held weekly for the first 3 months and then every other week for the remainder of the study. Groups were well matched. There were no significant differences in baseline characteristics. Our participants were predominantly female, like most weight loss studies, and the racial and ethnic distribution matched that of the Denver metro area. So findings, weight loss at 1 year was significantly greater in 4-3 IMF versus DCR. So this figure shows weight change from baseline in kilograms over the 12-month intervention with 4-3 IMF in orange and DCR in purple. The data is from our primary intent to treat analysis, all those results were similar in a completers analysis. And it's interesting that they track pretty similarly for the first about 3 months, and then they begin to diverge, with IMF achieving significantly greater weight loss than DCR at 12 months. And we do have an 18-month follow-up time point so that we will have some data on how people do on their own after completing the intervention. So changes in body composition tracked with weight loss with significantly greater fat mass loss and lean mass loss in 4-3 IMF. One really unique feature of our study was that we used the doubly labeled water intake balance method to objectively measure percent caloric restriction from baseline weight maintenance energy requirements. So almost all intermittent fasting studies to date have relied on self-reported dietary intake, which has issues with recall bias and multiple other biases, to the point where some people have actually argued that self-reported diet data is worse than having no data at all, because it leads you to draw erroneous conclusions. So we actually objectively measured percent caloric restriction. The bar chart shows DCR in purple versus IMF in orange, and you can see that neither group was anywhere close to the target of 34%. But 4-3 IMF did achieve significantly greater percent caloric restriction than DCR over both 0 to 6 months and over the entire 12-month intervention. So in other words, they were in fact eating less. And this figure shows total moderate to vigorous physical activity over 1 week using the ActivePal device. Both groups increased MVPA by about 75 minutes a week with no significant differences between groups. So combined, the objectively measured diet and physical activity data suggests that greater adherence to the dietary paradigm was what produced the greater weight loss. So quickly, other outcomes: both groups exhibited improvements in cardiometabolic risk factors, improvements in diet quality. IMF demonstrated greater improvements in binge eating and was also well tolerated. And so quickly, reasons why our study results might have been different from other studies. Paradigms involving only 2 fast days a week may be sufficient to produce comparable weight loss, but insufficient to enhance weight loss over DCR. And the flexibility of 4-3 IMF may have enhanced dietary adherence compared to the more rigid alternate day fasting schedule. So in our study, our participants were able to pick which days a week they fasted. And I'm so sorry, can someone give me a time check? I can't see the clock up there and I don't want to eat into Shelby's time. What's that? Perfect, thank you so much. The timer started like at 18, so okay, great. So I do have time to talk about some recent news headlines about potential cardiovascular risks of intermittent fasting and just touch on the evidence that led to these news stories. So this was based on data presented in a poster abstract at the AHA Scientific Sessions in March of this year. And a subsequent press release received national coverage with stories in USA Today, Washington Post, NBC News. So what the authors did was they performed a retrospective study of 20,000 US adults who participated in the NHANES and completed 2 24-hour dietary recalls in the first year of enrollment. They were categorized into 5 groups according to their daily eating window. And they compared this data to the CDC National Death Index database with a median follow-up of 8 years and a maximum follow-up of up to 17 years. They found that there was no difference between groups in all-cause mortality, but the risk of death from CVD was 90% higher in those with food intake greater than 8 hours, intake less than 8 hours relative to the 12 to 16-hour reference group. So the hazard ratio was 1.91 and the p-value was 0.06. However, I think there's a number of important limitations to this data. The first was that it was a poster abstract, so it has not been peer reviewed. It was a retrospective study, so it can suggest associations, but cannot really provide information about causation. Again, conclusions were based on 2 days of self-reported diet data. There was no comparison of other important health behaviors, such as diet quality, physical activity, sleep, total energy intake. And there was no comparison of other major CVD risk factors like diabetes, hypertension, or chronic kidney disease. There were some important differences in baseline characteristics. First of all, only 2% of the sample was in the less than 8-hour group. The less than 8-hour group had the highest mean BMI. They were 2 times more likely to be smokers and nearly 4 times more likely to be Black compared to the 12 to 16-hour group. So I think Pam Taub expressed this really well in a letter she and 34 other researchers sent to the AHA, and said really, unpublished, unvetted data presented in posters are meant to be discussed at scientific conferences, not used for press releases to alarm the public. There have been no prospective TRE or IMF studies that have shown any concerning signal regarding cardiometabolic risk factors, and studies in which these are measured consistently show improvements. So I really think that prospective studies and probably even better designed retrospective studies are needed. And I think really everyone can form their own opinion from this data and decide what feels right to them in terms of their practice pattern. But personally, it doesn't dissuade me from recommending TRE. I may avoid it for now, just in people with established CVD, but that is in part because the Mediterranean diet has proven benefit in this population. So in conclusion, TRE and IMF are part of a range of evidence-based dietary approaches for obesity treatment. TRE alone produces minimal weight loss. TRE plus dietary counseling results in similar weight loss as DCR. 5-2 IMF and ADF paradigms produce similar weight loss as DCR. And 4-3 IMF may result in greater weight loss than DCR. But again, I want to emphasize the best diet for any given person is the one they feel they can stick to over time. And so back to our case, we agreed on a goal of 5% weight loss because that has, we know that that will reduce her risk of developing diabetes. We discussed both of the paradigms and the evidence for them and what they look like in her day-to-day life, and she decided on TRE. She was referred to a dietitian to support healthy dietary choices. She lost 10 pounds over 6 months. Her hemoglobin A1C improved, and she feels she can maintain this eating pattern over time. So thank you so much for your attention. Thanks to all my co-Is, collaborators, students, and research staff. And with that, I'll hand it over to Shelby.
All right, now on to some endoscopic therapies to treat obesity. So another, I think we were talking earlier that these were kind of like maybe lesser known therapies for the management of obesity. So we're going to jump in. These are my disclosures. So Dr. Catenacci already brought this up a little bit, but talking about weight loss medications, and I'm just going to highlight this here as well. So there's many issues for patients who are on weight loss medications, and certainly cost and access to those are one of them. But the other thing is that people tend to not stay on weight loss medications long term. And this is a study from a large health system, and they had almost 2,000 patients that were on weight loss medications in this analysis. And what they found is that although semaglutide had the highest persistence, it was still only 40% of patients who were continuing to take the medication at the 12-month time point. And this has been consistent with other data, other real world data. So this is significantly more patients that were from Prime Therapeutics and Magellan Rx, which is an integrated pharmacy with medical claims data. And what they looked at, what they compared GLP-1 receptor agonist users compared to controls. And what they found in this analysis was that persistency at 1 year was only 32%, and beyond that was only 27%. The other kind of surprising thing, and a little bit shocking thing for all of our checkbooks, is that the annual cost of care significantly increased, and these weight loss medications, despite the fact that they caused weight loss, did not reduce cost in the rest of their care. So it was almost $26,000 to pay for that person's healthcare for that year, compared to the control arm that was same, otherwise matched, was only $11,500. So significantly more cost to actually be on these medications. And although they may have some benefit long-term, it's probably going to take years before you would see any of that cost benefit. So endoscopic bariatric therapies are an option that is a more cost-effective option. And we're going to talk about that sort of at the end of this talk. And there are many devices that have been developed, unfortunately, and there's also devices that may have some weight loss independent effects. The small bowel therapies, none of which are approved in the US yet, may have some weight loss independent effects on glycemic control and on MASLD. So these are the devices that have gotten FDA approval. These are the devices that didn't survive financially, especially with the pandemic. And unfortunately, most insurance plans don't cover these therapies. And these are the devices that don't have widespread availability, again, because of cost issues. So these are the only therapies the only devices that we have that are both FDA approved and have current widespread availability in the US. And that includes the Orbera balloon, which is approved specifically for weight loss, and the Overstitch device, which is specifically approved for endoscopic sleeve gastroplasty and revision of bariatric surgery for obesity treatment. So this is our outline for today. We're going to talk about the primary therapies, and then we're going to talk about what we think of as the secondary therapies, which is treatment of weight regain after bariatric surgery. So we just have published this guideline, which is a combination of the American Society for Gastrointestinal Endoscopy and the European Society for Gastrointestinal Endoscopy, and it just was finally published online April 19th. This is a huge document with about 50 meta-analyses. So if you want to learn more about these therapies, definitely check that out. But I'm going to refer back to this a couple of times. So first of all, who should these therapies be recommended for? And after reviewing the data, what we recommend is that endoscopic, bariatric, and metabolic therapies plus lifestyle therapy modifications, very important, just like Dr. Catenacci was talking about with time-restricted feeding or any kind of diet or weight loss program, is that lifestyle therapy increases, and that is having sessions with somebody who can help you with behavior modification and lifestyle therapy to review diet and exercise, that all of these therapies should be done in conjunction with lifestyle therapy. So we recommend these therapies with lifestyle therapy over lifestyle therapy alone, or lifestyle modification alone with a BMI of greater than 30 with or without an obesity-related comorbidity, or a BMI of 27 to 29.9 with at least one obesity-related comorbidity. And we have data to actually support this. So there's multiple studies that have included patients. These are observational studies that have included patients with BMIs below the range of 30. And you can see these here. And there's more than 10% total body weight loss, which favors the endoscopic therapies versus lifestyle therapy alone. And that's total weight loss. That's not lifestyle therapy subtracted. So that's not control subtracted. This is control subtracted. For the BMI of 30 to 39, this is subtracted weight loss. So 7% total body weight loss, that's control subtracted, favoring endoscopic metabolic therapies in the 30 to 39 group, which is for the balloons, that's the FDA indication. For BMI of greater than 40, again, this is not control subtracted. These are observational studies. And we have over 12% total body weight loss, again, favoring the endoscopic metabolic therapies. So we're going to talk about the intragastric balloons. And again, for our recommendations, we give recommendations both for the use of the intragastric balloon over lifestyle therapy alone, and then recommendations for how these patients should be treated. So including antiemetics peri-procedurally, pain medication, and proton pump inhibitors that should be used for the entire duration of balloon implantation. There's lots of different balloons that are in the US and around the world, but again, only the Orbera balloon has widespread availability. So we've got it separated into different categories. I like to always categorize things. So we think about the swallowable balloons versus the endoscopically placed. And with the endoscopically placed balloons, we have the fluid-filled, the air-filled, and the air and fluid-filled. Again, the only ones that are approved right now in the United States are the Orbera balloon that has widespread commercial availability, and the Spatz balloon, which has approval but does not have widespread commercial availability yet. We also, for the swallowable balloons, so these are swallowable. Obalon is a system that requires requires endoscopic removal. The Allurian balloon system is both swallowable and self-passable, so it passes out on its own as well. The SPATs, of those, the Obalon balloon system is also FDA approved, but not yet commercially available. And the Allurian intragastric balloon is undergoing FDA trial right now. We just completed our last subject here at this center, I think 2 weeks ago. So that study will be wrapping up in October. We do have CPT codes that are now available for both placement and removal of the endoscopically placed and endoscopically removed codes. But although we have these codes, they are still not covered by insurance yet, but getting CPT codes is the first most important step. So when we look at these balloons and we kind of compare the weight loss between them, there is, first of all, an effective sham. So some of these studies were done in a sham-controlled study design that does suppress weight loss. And we've seen this in multiple different endoscopic metabolic therapy trials. When we look at registry data and post-market approval data, we see that the weight loss is pretty similar across the balloons. The SPATS balloon actually stays in longer, so it's an 8-month balloon and is adjustable compared to the other balloons. So it has a little bit more weight loss, probably because it stays in a little bit longer. In terms of adverse events, the swallowable balloon, the Obalon balloon, has the least amount of serious adverse events compared with the fluid-filled balloons, and that's pretty consistent. In terms of the non-serious adverse events, one of the most common things that we see, especially with the fluid-filled balloons, can be reflux. Now, a lot of these patients have nausea, vomiting, abdominal pain in the peri-procedural area. It usually lasts 4 to 7 days, and then that actually resolves. So we give medications to manage that. Things that last a little longer are things like the reflux that can occur more, again, like I said, in the fluid-filled balloons. So will one balloon become dominant? Well, the Orbera balloon has a long history. It's a reasonable safety profile. We do have CPT codes now. It's not adjustable. It does require procedures for placement and removal. It's not covered by insurance. FDA approval is 30 to 40, but again, we have data outside of that BMI range, although that is considered off-label use. The SPATS balloon has the highest weight loss in the US trial. It's adjustable, reasonable safety profile, requires more procedures though. It is adjustable, but that requires you to do an additional endoscopic therapy. It is approved for BMI of 30 to 40, but again, we have data for patients who are outside of that range. The Obalon balloon is the best safety profile of all the US balloons. It has the CPT code for removal, but not placement because that's swallowable. It's not adjustable, but there's 3 different balloons that are placed over the period of 12 months, so it's kind of adjustable. It requires 1 endoscopic procedure for removal, currently not in production in the US, but still FDA approved and may come back. The Allurian balloon, it's procedureless. You swallow this balloon. You do need some either digital X-ray or fluoroscopy for placement. Low rate of serious adverse events, similar to the Obalon balloon. It's not adjustable and currently not yet approved in the United States, but approved in almost every other country around the world and has more widespread use around the world than any other balloon at this time. So will one become more dominant? I don't know the answer to that, but we'll see what happens in the future. So we're going to switch gears and talk about endoscopic gastric remodeling procedures. And again, we've got recommendations for this. We do recommend these procedures with lifestyle therapy over lifestyle therapy alone. And then we do have some additional recommendations for using antiemetics, pain medication, prophylactic antibiotics peri-procedurally, and then short-term use of proton pump inhibitors. Patients don't have to be on proton pump inhibitors long-term with these procedures, only for the first 4 to 6 weeks after the procedure. We have a number of different devices that can be used for this. We do actually have 3 of them that are approved in the United States. Only one, the OverStitch device, has specific indication for obesity, although we were using it before it had that specific indication when it only had the 510(k) approval for tissue apposition in the GI tract, of which the incisionless operating platform and the Endomino also have that indication, so can be used for endoscopic gastric remodeling. The automated device, the EndoZip, so it's completely automated. You put the device in, you push it, you suction down so it brings the stomach up to it, and then you push a button, it does the suturing itself. That one is not yet approved in the United States. No study has been started in the US, but there are trials ongoing in Europe right now. So this is endoscopic sleeve gastroplasty. This is going There we go. Now it's speeding up a little bit. This is what it looks like. We have a suturing device. It fits on the end of the endoscope, and then everything is done through the patient's mouth, so no external incisions, and they go home same day after this procedure. In this particular patient was a female, age 27, no comorbidities. Baseline BMI was 42.5, and initial weight was 288 pounds. By 6 months, she had lost 17.4% total body weight loss, but her goal was to get under 200 pounds. So you can see we're kind of grabbing the tissue, pulling it up into our suturing device, and then placing bites through that. I'm just going to speed this up here so that you can kind of see what the end looks like. So it's very similar in appearance. Let me back that up just a little bit. So it's really similar in appearance to the diameter of what the stomach looks like after a sleeve gastrectomy, but we're not cutting anything out. We're just sewing everything up and turning the stomach from a bag into a tube. All right. So this is a different patient 4 months after endoscopy. You can see that there's a little bit loosening of my second row, but my first row of sutures is completely intact. This patient had 16.5% total body weight loss at 6 months. The MERIT trial was an open label randomized controlled trial of endoscopic sleeve gastroplasty, and the patients crossed over at 1 year. So at the 1 year mark, there was significantly more weight loss, 13.6% versus 0.8% in the control arm. Then the control patients were able to get the procedure, and then they lost about the same amount of weight. But what you can see is that at 2 years, weight loss is very well maintained in the ESG group. There was only a 2% serious adverse event rate, although there were 4% of patients that required hospitalization for accommodative symptoms, so nausea, vomiting, and required some IV fluids for that. But that's just hospitalization that was less than 24 hours. Otherwise, it's considered a serious adverse event if it's 24 hours or more. In terms of non-serious adverse events, there was 92% of patients had some kind of symptom after the procedure, and mostly was related to either mild abdominal pain or mild nausea. 66% of reported adverse events were related to accommodative symptoms, again, which was just that nausea, vomiting, and abdominal pain that mostly resolves. For most patients, that's going to resolve within 1 week. When we look at analyses of these, so we did a meta-analysis including all studies, including observational studies with all of these procedures, which included endoscopic sleeve gastroplasty using the overstitch, devices using Endomina, procedures using the Endomina device, and procedures using the incisionless operating platform. And weight loss at 12 months with these procedures on average was 17.3% total body weight loss. So pretty consistent across all of these trials. And this included over 5,000 patients in this meta-analysis. We also have some medium-term weight loss data with this procedure as well. So this included a single center experience of 216 patients. Weight loss with these patients at 5 years was 15.9% total body weight loss, and 61% had greater than 10% total body weight loss at that 5-year time point. The other thing that's really important to note about this is that even for patients who didn't follow up in that clinic, they were at least still, this was at Cornell, and so they were at least still coming to the medical center. So they were able to get weight data on 80% of these patients at that 5-year time point. So it's a really much higher percentage of patients that we see than we see with most bariatric surgery follow-up studies. There's also a meta-analysis that included 1,800 patients. At the 18 to 24 month time point, 17.2% total body weight loss. Adverse events in these series, 1.3 to 2.2%, still at least 50% of those adverse events were still accommodative. So nausea, vomiting, abdominal pain requiring very short-term, 24 hours or less, IV fluids and medications. The largest study, which has looked at follow-up in these patients, was from the Middle East. It's important to remember that with the the different parts of the world have different responses to weight loss. In general, Europe and South America have the highest weight loss with endoscopic bariatric therapies. US comes after that. The Middle East is actually after that. The Middle East also has the highest rate of obesity in the world. And this study was looking at, it was a retrospective analysis, a non-inferiority propensity score matched comparative study that included 3,000 patients in both groups. So the endoscopic sleeve gastroplasty group and the surgical sleeve group. They had similar BMIs. Weight loss at 3 years was 14% for the ESG group and 19% in the laparoscopic sleeve gastroplasty group. So again, a little bit less weight loss overall with surgical and endoscopic procedures in the Middle East compared to the US. but they had very similar remission of comorbidities. Diabetes reduced in a similar amount, although a little bit less with ESG, similar for dyslipidemia and similar for hypertension, very few serious adverse events, and there were very few revisions. So there was a repeat ESG in about 1% of patients who had a sleeve gastrectomy, and conversion to sleeve gastrectomy occurred in about 2.7% of patients. And they had very high follow-up. So of the patients who could have followed up at 3 years, they had about 85% follow-up for ESG compared to 71% follow-up for sleeve gastrectomy. So really high, I mean, really good follow-up with these patients and good data. In terms of cost effectiveness, there is significant savings with these therapies compared to semaglutide. So we get similar weight loss, as you see with the weight loss medications, but the cost is significantly different. So when we look at the ICER, that's like almost $600,000 less. I mean, this is, or $600,000 dollars per quality difference. I mean, this is really big. And for non-dominance with an ESG cost of $17,229, and by the way, that is not what the cost of this is here at this institution. It's significantly less than that. Semaglutide has to cost $3,591 or less per year with 20% or less dropout. We already know it's 60% or more patients drop out with this over 5 years in order just to be equivalent. So we know that it already doesn't match those things, and the cost is not going to come down to $3,500 a year anytime soon. So I would advocate for coverage of these procedures, and hopefully someday soon we'll see that. All right, we are going to finally talk about a revision of gastric bypass and sleeve gastrectomy. When we talk about revision of gastric bypass, that's with the transoral outlet reduction or TOR procedure, and then sleeve gastrectomy revision. So I'm going to go through just a quick case. 47-year-old woman who originally had class 3 obesity. She had a gastric bypass in 2010 at a weight of 311 pounds. She lost 121 pounds at her nadir, but then started regaining weight and had regained about 44.6% of her weight by July 2019, reported being able to eat 3 times as much at a meal compared with the first few years after surgery, and really didn't feel restriction anymore. So the pathophysiology of weight regain after gastric bypass is really likely multifactorial, but we know that diameter of the gastrojejunostomy correlates with weight regain. And this is an analysis of 165 patients, 59% with weight regain of more than 20%. So when we think about weight regain in patients with gastric bypass, it's common for patients to regain some weight. Up to 20% of the weight that they lost is considered normal, but regain of more than 20% of the weight that they lost is considered not normal. 41% of these patients had weight maintenance. They all underwent endoscopic or EGD for a variety of clinical reasons, but not weight loss. And what you can see is there was a significant correlation between the diameter of the gastrojejunostomy and percent of weight regain. There's multiple different ways that we can actually reduce the gastrojejunostomy. We can use argon plasma coagulation alone, and this is kind of like cautery, but it shoots a beam of argon plasma out and we can just kind of burn around. There's endoscopic transoral outlet reduction, and that's where we use either APC or a modified endoscopic submucosal dissection, and then we sew that anastomosis down. Sclerotherapy has been studied, but is not used anymore, and is really not available, so I'm not going to talk about that at all. We'll talk about APC resurfacing technique. We use low flow, high watt, so it's a lot of energy, and we really just try to essentially induce scarring. It does cause ulceration to start out with, but then it ultimately results in scarring, which causes that anastomosis to shrink down. Does require high-dose PPI therapy, liquid diet, and sucralfate. I use sucralfate, although that's not included in all of the publications. We repeat this every 8 to 10 weeks until the stoma is reduced. Some people respond really well to this. Some people don't respond at all, and their anastomosis just never shrinks down with it. We also have the transoral outlet reduction technique. And so this is where we actually do, again, either argon plasma coagulation, so the first step that you just saw before, plus an endoscopic submucosal dissection, and then we sew the anastomosis down. There are different types of suturing, interrupted or purse string, and you can kind of see these in this cartoon here. Purse string, essentially what we're doing is we're taking bites all the way around that anastomosis, and then we put a dilating balloon and size it right to 8 millimeters and tighten that down around it so we know exactly how we're sizing that anastomosis. In the first randomized sham controlled trial, this was not with a purse string, this is just with interrupted sutures. They were able to, and it wasn't a full thickness suturing device either, they were able to demonstrate that Patients who got the revision both lost weight on the liquid diet because they went on a liquid diet for 6 weeks after the procedure and then maintained that weight loss, whereas the other group started regaining weight right as soon as they came off of that liquid diet. We also have since then done additional trials looking at full thickness devices, and we get significantly more weight loss with the full thickness device. This study compared the TOR procedure with suture patterns. So we were looking at the purse string versus the interrupted sutures. And what you can see is that the purse string, they get similar weight loss initially, but purse string is just more durable. And it's probably because there's the forces around that anastomosis are radially distributed, and it reduces the chance that any of those sutures are going to blow. We also have published data from our center here. We have a really high amount of weight loss. So when we look at our purse string versus our non-purse string, we have 13.5% total body weight loss at 12 months for our patients that currently undergo the current technique that we use with purse string technique plus suturing in the pouch. And we also found that suturing the pouch was significantly correlated with weight loss. So the smaller we made the pouch, or the more that we were able to reduce it, the more weight loss that we got with patients. We did have two serious adverse events in this group. A patient who was not compliant with medications or diet had a perforation, and that was treated, and she without sequela. And then we had a patient who started bleeding after getting heparin with dialysis. This is kind of what this looks like. So this was that patient that we were talking about that had in the initial case presentation. So first we do that argon plasma coagulation all the way around the anastomosis. And she had a large anastomosis. It was 30 millimeters, so pretty large around, and her pouch was 6 centimeters long. When we sutured, we take bites, again, all the way around. I do this about half a centimeter apart. We did 11 bites all the way around, and then we cross that last bite. So we're kind of locking that suture in. And the ultimate diameter was 8 millimeters, and pouch length was 3 centimeters after sewing up the pouch as well. This patient did have intermittent vomiting. You can see here that balloon going in, and I'm going to cinch down around that balloon again, just like pulling a purse string shut. And then you can see the difference in the size of that anastomosis. There it is. It is much smaller than it was when it started out. And then I'm just going to speed this up here again so you can see what the final looks like after we sew up the pouch as well. So this patient did have some intermittent vomiting that required a persistent modified diet for 6 months. So these patients are on a modified diet for 6 weeks total, 3 days of clear liquids, then full liquids for 6 weeks before going on to pureed for 2 weeks, and then a soft diet after that. She lost 19% total body weight at 12 months and was still maintaining that at 23 months. So it is, we do see consistent weight loss maintenance with this procedure. This is a analysis, or this is a series out of Brigham, which has really been doing this the longest. And they have 5-year data that demonstrates 8.9% total body weight loss at that 5-year time point. And they've also compared this to surgical revision. And what you see is that although there is a little more weight loss with the surgical revisions at year 1 and year 3, there is no significant difference at year 5, but there is a significant difference in adverse events, both non-serious and serious adverse events. And in fact, there were no serious adverse events in the endoscopic group, but there was 19% serious adverse events in the surgical group. We also do sleeve revision, although there's less data on this than with gastric bypass revision. This was a retrospective analysis of 82 patients, and at 12 months after the endoscopic revision, they got an additional 16% total body weight loss. We've done a few of these patients here. This is a patient who had class 2 severe obesity. She regained all of the weight that she had after sleeve gastrectomy, and it's pretty, I know not all of you are gastroenterologists, but this is a pretty dilated sleeve gastrectomy. And then we sewed it up. So that's sitting at the same spot from the endoscopic view. And we've just, again, sewed that sleeve up. This patient had 13.2% total body weight loss at the 7th month follow-up. So in conclusion, endoscopic, bariatric, and metabolic therapies have weight loss dependent and weight loss independent effects for the small bowel therapies, can be used for weight regain after bariatric surgery as well. There's only 2 devices with widespread availability in the United States, but there's multiple devices with FDA approval that aren't commercially available right now, but maybe in the near future, and multiple devices that are currently undergoing pivotal trials in the US. And that is it. And this is the code to scan to get your CME and mock credit. And I think we're going to take questions now. So Dr. Catenacci,
Yeah.
if you want to come up.
We've got a couple minutes for questions. Very popular topic. I'm sure there's plenty of questions in the audience, and we have one from the get-go. Dr. Ernest, coming right at you.
Thanks to you both for a great talk. I'm interested in the endoscopic procedures, and is there, what's the difference in safety relative to surgery, and second, insurance coverage? Is it how hard is it to get people in?
It's hard to get insurance coverage for the primary therapies. We get pretty good coverage for gastric bypass revision. So we do more revisions than we do of primary therapies. Primary therapies, for the most part, patients are paying out of pocket for. Our price, so you saw like what the analysis was at the $17,000, but for us, like our package price for that is just a little under $11,000 for an endoscopic sleeve gastroplasty, and that actually includes a year of dietitian follow-up visits. But unfortunately, we just don't have a lot of, we don't have significant coverage yet. In terms of serious adverse events, low serious adverse events with the endoscopic sleeve gastroplasty. So with the balloons, there have been deaths reported with the balloons. There have been, I think, 5 deaths total noted. So it's still less than 0.03%. There's a risk of pancreatitis less than 0.01%. So risk of pancreatitis with semaglutide closer to 0.1%. So it's a magnitude of order less than that. Other potential side effects. So when we think about sleeve gastrectomy, one of the big things that we think about in gastroenterology, like long-term kinds of things, because you have the immediate adverse, or you have the immediate potential complications, and then you have the long-term complications. So the immediate complications, like cardiovascular stuff, we don't see that with the endoscopic bariatric therapies. In terms of things like fistulas and infections, we also don't see that very often, but that can happen. So rate of that in endoscopic sleeve gastroplasty is less than 0.06%. Risk of perforation is also less than 0.06%. Exactly how low, can't really tell you, because we don't have these large series that we have with bariatric surgery. In GI, again, we think about reflux a lot, and because of Barrett's esophagus, we do know that there's an increased risk of Barrett's esophagus after sleeve gastrectomy. Risk of reflux is much lower in endoscopic sleeve gastroplasty compared to sleeve gastrectomy, and that's related to kind of the differences in anatomy of these two procedures.
I think we have time for one more question. I'll finish up. Curious about the addition of medications to time-restricted eating. Do you think that's going to become a thing and an area of future study? Will that be additive? What are your thoughts?
Yeah, great question. I thought about putting a slide in on that. There's really no data to date on that, but I think it's a very interesting area. I think with the newer nutrient sensing hormone weight loss agents, the weight loss is so high, with some of these medications coming down the pipe, we're looking at 21%, 26 for tirzepatide, 26% for some of the agents in trials, that it seems like the weight loss medication is doing a lot of heavy lifting. But the issue is that, again, cost of those medications. So could we combine some of our older medications like phentermine topiramate, which produces about half the weight loss as semaglutide at 1/50th the cost? So could we combine some of these older medications with some of these more effective intermittent fasting strategies to achieve weight loss closer to the newer agents? I think that's a great question and great area for research.
Well, thank you both. Let's give them another round of applause.